Hi, everyone. My name is Sara Arian. I'm a double board certified physician in OBGYN and a reproductive endocrinology and infertility specialist at Boston IVF here in Massachusetts. Thank you all for joining me this evening. I'm excited to be here. We are here in honor of National Infertility Awareness Week, and I'm here to educate on fertility, advocate, and promote knowledge of infertility, what I'm very passionate about, and empower you with knowledge and information about your reproductive health. And together, hopefully we can change the negative stigmas around infertility. So over the past week, over the week of the National Infertility Awareness Week, our wonderful team at Boston IVF has been putting together educational series, seminars, and live Q&A sessions, including tonight, to help support people with infertility and our community, as well as to help educate, advocate, and improve access to care, and to protect reproductive care and to raise awareness about this important topic and condition. So join me tonight as I will be discussing uterine fibroids and how they relate to infertility. And please bring all of your questions. You can send me your questions and type your questions in the Q&A box, and I will go through your questions shortly. So before we go over all the questions and start the Q&A session, I would like to give you some information, some basic background information, provide an overview about uterine fibroids and what you should know. Infertility is a disease that is sadly impacting 1 out of 6 people and millions of people of reproductive age. And when we talk about the underlying causes of infertility, underlying etiologies, approximately 1/3 of infertility causes are female-related, 1/3 are attributed to male factors and male partners, and 1/3 can be caused by a combination of male and female factors, or sometimes can be unknown or unexplained. So among one of the most common causes of female infertility are structural and anatomical causes, including uterine fibroids. Uterine fibroids are also known as myomas or leiomyomas, and they're very common. They can occur in up to 75% of people of reproductive age with a uterus. These are benign overgrowths, benign tumors or overgrowths of the myometrium, or the muscle part, the muscular component of the uterus. What are some of the common symptoms of uterine fibroids? The symptoms of fibroids can vary. Sometimes they can be asymptomatic, but they can also impact your quality of life by causing severe issues and symptoms. So some of the classical symptoms of uterine fibroids include heavy or abnormal uterine bleeding, severe menstrual bleeding, which is also known as menorrhagia. They can cause painful, severe cramping, and what we call bulk symptoms, which are symptoms of abdominal pressure and discomfort. Fibroids can also be associated with infertility. They can be associated with increased likelihood for having early miscarriages and pregnancy losses, as well as recurrent pregnancy loss. And they can cause problems and difficulty when you're trying to conceive. What are some of the causes of uterine fibroids? How do these fibroids develop? The exact causes of uterine fibroids are really not very well known, mostly unknown, but some of the factors that might play a role in the growth of uterine fibroids include genetic factors, including genetic mutations in certain genes. Sometimes they can be related to hormones and hormonal hormones such as estrogen, progesterone, and growth hormones. And sometimes they can be familial and hereditary factors. The bottom line is that they are multifactorial and they are related to many factors. Depending on the location of uterine fibroids, fibroids are classified into different kinds and different types. And some of the most common types of uterine fibroids include subserosal fibroids, intramural, and submucosal uterine fibroids. So fibroids that are inside of the uterus, inside of the cavity of the uterus, are also known as submucosal uterine fibroids. They're fibroids that are in the myometrium, or the muscle layer of the uterus, the muscular component of the uterus, and these are known as intramural uterine fibroids. And then there are fibroids that are outside of the uterus, and these are known as subserosal fibroids. These are outside of the uterus, outside of the cavity of the uterus. So when we see patients who are suspected to have uterine fibroids, there are different diagnostic techniques and ways of testing to diagnose and better characterize uterine fibroids. And some of these imaging studies include a pelvic ultrasound or a vaginal ultrasound, water sonogram or water ultrasound, also known as hydrosonogram or saline sonogram. And sometimes we use more advanced techniques, including pelvic MRI. Now, can fibroids impact fertility and the ability to conceive? The answer is yes. Fibroids can impact fertility through different mechanisms. So fibroids can change normal uterine and pelvic anatomy, causing anatomical and structural distortion of the pelvic anatomy. They can cause blockage of a fallopian tube. They can also make it hard for the embryo to implant inside of the uterus. They can make the cavity of the uterus a suboptimal environment for implantation of an embryo. They can cause complications in pregnancy. Sometimes they grow in pregnancy. They can cause pain. They can go through changes, including degeneration. They can cause OB complications, including increased risk for having preterm birth, intrauterine growth restriction of the baby. And they can also impact the ability to stay pregnant. They can be associated with increased risk for early miscarriages and recurrent pregnancy loss. The fibroids that are larger in size, and especially if there are large and many numerous, they can cause anatomical distortion. They can negatively impact the cavity of the uterus. Sometimes, even if they're not inside of the cavity of the uterus, while they're inside of the muscular part of the uterus, they can still press against the cavity, causing distortion. And so really the location of the fibroids matters when it comes to the impacts of fibroids on fertility. Size also matter. So intramural fibroids that are large in size, typically 5 or greater than 5 centimeters in size, may again cause distortion of the anatomy and negatively impact fertility. Now, does removal of uterine fibroids improve fertility and pregnancy outcomes? So let's talk about this. Surgical removal of uterine fibroids is also known as surgical myomectomy. And there are medical indications for performing a surgical myomectomy for certain patients. So for subserosal fibroids, now remember, these are fibroids that are outside of the uterus. They're outside of the cavity of the uterus. They typically do not impact implantation. And typically, we don't do anything about these fibroids. We leave them alone. For the larger fibroids, or the fibroids that are symptomatic, meaning when the individual is becoming symptomatic and experiencing symptoms such as heavy bleeding, sometimes individuals present with severe blood loss, including anemia, need for blood transfusion, severe menstrual cramping, and pelvic and abdominal pain that is negatively impacting the quality of life. In these individuals, we talk about and we discuss advantages of surgical myomectomy. Going back to intramural fibroids, again, depending on the size of the fibroids, if they're larger, greater than 5 or greater than 5 centimeters, and also if we think that they are causing any type of anatomical distortion, we may recommend a surgical myomectomy. Now, for submucosal fibroids, we oftentimes do recommend surgical removal of these fibroids to help improve fertility and pregnancy outcomes. There are also different ways a surgical myomectomy can be performed. So for fibroids that are submucosal and intracavitary fibroids, oftentimes we're able to perform the procedure, the myomectomy, hysteroscopically. So we call this a hysteroscopic myomectomy using a hysteroscope device. And this is a procedure that can be done vaginally. We insert the hysteroscope device through the vagina and oftentimes are able to remove the fibroids hysteroscopically. Now, for larger fibroids, bigger intramural fibroids, open surgery, abdominal surgery, myomectomy may be indicated. An abdominal myomectomy can be performed as an open surgery where we would make an incision on the abdomen to expose the uterus and find and identify the location of the fibroids and get them removed. Now, most recently, a lot of physicians perform robotic or laparoscopic myomectomy, and these are minimally invasive techniques that can be performed for the right surgical candidates, again, depending on the size and the location and the number of these uterine fibroids. So really, when it comes to deciding about surgery, clinical history plays an important role in determining whether surgery is going to be indicated or not. Now, remember that surgical myomectomy can have its own risks and complications, so we need to keep that in mind. And really, we need to overweigh the risks versus the benefits of surgery, meaning sometimes recovery from a big surgical myomectomy can take time, especially for the uterus to heal. Sometimes these individuals may have to wait for at least 4 to 6 months before they can try to get pregnant again, or before we can proceed with IVF or fertility treatment. And this is the time that is required for the uterus to heal. Otherwise, there may be a risk for uterine rupture with the subsequent pregnancy. There's also risk for scar tissue formation, adhesion formation that we should also consider when we talk about surgical myomectomy, and obviously all the other risks that are associated with any surgical procedure. So really, we talk about, possible risks and complications, and we really try to individualize and overweigh risks versus benefits of surgical procedures and surgical myomectomy. But in summary, we typically recommend surgical removal of submucosal fibroids to help improve fertility and pregnancy. And for intramural fibroids are really individualized patients based on the patient, clinical history, age of the patient, other testing, including ovarian reserve testing, underlying infertility diagnosis, also based on the size and location of these fibroids and how much of an impact the fibroid can have on the cavity of the uterus. Also, sometimes when fibroids are large enough that are preventing access to the ovaries at the time of IVF and making an egg retrieval procedure more difficult, then in these cases, we would need to consider surgical removal of the fibroids before proceeding with IVF in order to help improve access to the ovaries at the time of egg extraction or egg retrieval. Now, there are also medical management options, so medications that are available for uterine fibroids, mainly for symptomatic management of uterine fibroids, and these are mainly hormonal medications, and these are, for the most part, contraindicated in our patient population in patients who are actively trying to conceive. So to summarize, before starting our Q&A session, if you have uterine fibroids, please know that you're not alone. This is a very common condition, and please seek help from a fertility specialist to see what your options are. So with that, I am going to now go over the questions that I have received. So starting with these questions, first question, what is the difference between a fibroid and a cyst? Do both impact fertility? So a fibroid, as I mentioned, is a benign overgrowth of the uterus, of the muscle, the muscular part or the muscle of the uterus. And as I mentioned, it can impact fertility. Cysts commonly involve the ovaries. So a cyst is also a benign overgrowth, usually of the ovarian tissue. So we see cysts commonly within the ovaries. And cysts are less likely to impact fertility. Usually a lot of ovarian cysts are simple cysts. They come and go, and they're less likely to be impacting fertility, unless they are endometriosis-related cysts, including an endometrioma, which may sometimes impact fertility or the outcomes of IVF. So the second question that I got, what is a hysteroscopy? Is it surgical? Is it safe? Will I feel pain? So again, as I explained, hysteroscopy or hysteroscopic myomectomy is one way of performing a surgical myomectomy. This is done vaginally. It's a very minor procedure. It's done as an outpatient surgical procedure. And typically we'll have you come to our outpatient surgical center and we put you to sleep. Typically it's a very light, mild IV sedation just to make sure you feel comfortable for about 30 to 45 minutes. And the procedure can be done where we would be able to shave and remove the fibroids, the intracavitary fibroids from the cavity of the uterus. So oftentimes you're not going to feel any pain during the procedure, and really minimal pain and cramping after the procedure, and recovery is usually pretty quick. What will be your advice? This is my next question. What will be your advice between a surgery and an embolization? Why? And how soon to wait after one of these procedures to do IVF? So embolization, uterine artery embolization, is a minimally invasive type of procedure that can be performed for certain types of fibroids and also a certain patient population. Typically, we do not recommend this procedure for our fertility patient population, people who are going to be trying to conceive. Because this procedure has its own risks. Sometimes, there could be a potential for harm to the ovaries and compromising the ovarian blood supply. And in general, we do not recommend uterine artery embolization for people who are going to be trying to conceive or undergoing fertility treatment, because it can also impact the environment of the uterus and the endometrial cavity and can negatively impact implantation of an embryo. So there's another question. These are great questions. Keep them coming. Does a polyp in the cervix reduce the chances of pregnancy, and would a hysterosonogram, or I guess they mean a hysteroscopy, remove it? So cervical polyps, also common, benign lesions. Typically, a small cervical polyp does not impact fertility. Sometimes polyps are associated with bleeding, intermenstrual bleeding, bleeding in between cycles, or postcoital bleeding, bleeding after sex. And if it becomes symptomatic, it can easily be removed. If it's small, it can be removed in the office without need for any additional procedures or a hysteroscopy. Love, you're my MD. It's great to watch this video before meeting you. Thank you so much. I'm very, very excited to meet you, and hopefully we'll be able to help. Next question, how long after fibroid surgery can I start IVF? I think I mentioned about this briefly in my talk earlier. So if it's a major surgical myomectomy, whether it's done laparoscopically, minimally invasive, or an open abdominal myomectomy, we would want you to wait for, so the data is really mixed. Actually, we were just discussing about this yesterday after a surgical myomectomy case that I performed, and the data is really mixed. but typically most data and most evidence recommend waiting on average of about 4 to 6 months, sometimes even longer, for the uterus to completely heal before you can proceed with IVF, or before putting an embryo back, before transferring an embryo. No, now, sometimes we would do IVF, we can freeze embryos and then proceed with surgery, let you have some healing time and recovery before we can go back and transfer and put back an embryo. Is natural birth possible after a surgical myomectomy? That's another great question. And the answer is that if this is a major surgical myomectomy where we are removing fibroids from the contractile part of the uterus, or if we get into the cavity of the uterus at the time of surgical myomectomy, then yes, the recommendations are, or I should say no, the recommendations are against having a vaginal birth and laboring. And we would highly recommend having a C-section, a cesarean delivery, in order to minimize the risk for having a uterine rupture at the time of delivery. Really appreciate this. Of course, do fibroids affect egg quality? That's a great question. Not necessarily. We don't think fibroids. So fibroids, again, overgrowth of the muscle part of the uterus. Egg quality really has to do with your age, which is the most important factor determining the success of IVF fertility treatment, and just in general, the ability to conceive. That is the most important factor that can impact the quality of your eggs. So fibroids, a uterine fibroid by itself may not necessarily impact egg quality. How common is it for a fibroid to shrink or go away on its own? Well, I mean, again, typically the ones that are large are less likely to go away on their own. Now, fibroids are hormone dependent. So as long as your ovaries, for individuals who have ovaries, as long as the ovaries are secreting hormones, then these fibroids can continue to grow. And really, once you reach menopause and once the ovaries stop secreting hormones, that's when we can see some shrinkage of uterine fibroids. Outside of menopause, they can continue to grow. If they're already bigger, the chances that they are going to shrink on their own are going to be lower. Just wondering if I can carry a baby while having fibroids. Yes, absolutely. There are many people out there who may have uterine fibroids, may be completely asymptomatic. We may not know about these fibroids, and sometimes they're found incidentally at the time of pregnancy ultrasounds. And again, there are many people who are able to conceive and get pregnant while having these uterine fibroids, and they continue to do well. Sometimes the fibroids remain completely stable without any changes during pregnancy, and many of these people are able to still have a vaginal delivery as long as these fibroids are small and not obstructing the way. Another question is, anything that you would suggest for prolonged periods due to fibroids? I'm trying to conceive and would not prefer going on birth control. So really, again, limited options when it comes to medical management, as I mentioned, and as you have mentioned here, we're trying to avoid hormones. There's a medication called tranexamic acid, and that's an oral medication. Obviously, you need to talk to your physician. It's a prescribed medication that has to be prescribed by your physician if they think that you may benefit from this medication. And it can be taken just short term for a short period of time. It's usually taken within the first few days of your menstrual cycles to help minimize the amount of bleeding. Other options are mainly hormonal, again, not options that we would be using or prescribing when you are trying to conceive and trying to get pregnant. So best is to get those evaluated to find out what exactly is going on, and is the abnormal bleeding also impacting your ovulation or not? What is the difference between a polyp and a fibroid? Are polyps just as impactful to fertility? That's a great question. So polyps are benign overgrowth, growths of the lining of the uterus, so the endometrial lining of the uterus. And these are also benign. They're very, very common. And polyps have been also shown to negatively impact implantation of an embryo. And if the embryo does implant, because these polyps do not have adequate blood supply and blood perfusion, this can impact blood perfusion to the embryo, and they can be associated with increased risk for recurrent pregnancy loss and early miscarriages. So we oftentimes do recommend a polypectomy, which can also be done hysteroscopically through the vagina. This can be done as an in-office polypectomy, hysteroscopic polypectomy, or can be performed in the operating room. And we actually offer both services here at Boston IVF. Does a fibroid need to be a certain size to be removed? I think I also mentioned about this. So again, the data is really mixed, and we have to take into account several other factors, including the location, as well as the type of the fibroids. But when talking about an intramural fibroid, most data have shown that fibroids that are 5 centimeters or greater in size, those are the ones that can negatively distort and impact the anatomy of the pelvic cavity, and those are the ones that are recommended to be removed. But again, we individualize based on many other factors. And can fertility medications cause fibroid growth? That's a great question. So medications that we use mainly for IVF, these are hormonal shots, injections, and we know that fibroids are sensitive to hormones. And for the most part, we're not super concerned about growth of the fibroids as a result of taking these medications, because you would be taking these medications, either shots, injectables for IVF, or oral fertility medications for a very short period of time. Most of these hormones are they don't have a very long half-life. They don't stay in your system for a very long period of time. And so fibroids are not going to be exposed to these hormones for a very long period of time. So we're not typically concerned about growth of uterine fibroids while you're going through fertility treatment or an IVF cycle. Aside from the effects of fibroids and potentially affecting the physiology of the uterus, does submucosal or intramural can cause any local inflammation that would prevent embryo implantation? Yes, they can. And that is one of the other thoughts, or one of the other hypotheses, that, with the submucosal fibroids, as well as the intramural ones that are pressing against the cavity, sometimes they can, especially the submucosal ones, sometimes they can cause local inflammatory changes that can make the cavity of the uterus a suboptimal environment for embryo implantation. Can you get pregnant naturally after having an IUI? Okay, this is another question, not related to fibroids, but just a general question. Yes, there's always a likelihood for pregnancy after fertility treatment, whether it's IUI or even IVF. Less likely if you have required to undergo fertility treatments. The chances are that you are going to likely need it again for future pregnancies, but it can certainly happen. How are fibroids diagnosed? So we typically start with a vaginal pelvic ultrasound. We investigate the anatomy of the uterus, and if they are large enough, we can identify them based on an ultrasound. And then we can also order some more specific diagnostic testing and imaging studies. So a hydrosonogram can be performed to visualize the impacts of the fibroids on the uterine cavity, and if they are causing any cavity distortion. We can perform a 3D ultrasound, and for surgical planning and mapping the uterus and the uterine fibroids, typically prior to surgeries, sometimes we order a pelvic MRI to better understand the exact location and the proximity of the uterine fibroids to the cavity of the uterus. How would, I went too far in advance. I think I may have missed a question. So there's another question that I got. So how long after childbirth can I go back to IVF treatment? So again, another general question, not necessarily related to fibroids. So this all depends on many factors, obviously, your age, underlying diagnosis, as well as the type of delivery, whether it's a vaginal delivery or a C-section. So after a vaginal delivery, typically we recommend at least 6 months or so for the uterus to completely heal. And then typically we recommend anywhere between 12 months or even longer after a C-section before you can restart the process of fertility treatment and IVF. It also depends on if you're breastfeeding or not, because most of the medications that we use, the injections that we use for IVF are contraindicated in breastfeeding. So we would want you to stop breastfeeding prior to pursuing IVF treatment and fertility treatment. Is there a pro to having surgery with a fertility physician? I think there is. A lot of us do think that there is, because some of us fertility specialists who are also specialized in these types of surgeries, myomectomies, we're just more careful when it comes to the uterus and preserving and maintaining the normal uterine tissue in order to help with outcomes and successful pregnancy outcomes in the near future, as opposed to someone who may not necessarily be very familiar with the anatomy of the uterus, the fibroids, and maybe more aggressive in their surgical techniques when it comes to removing these fibroids. Are there any supplements or recommendations to try to reduce the inflammation in the uterus caused in the area of the fibroids when we're trying to conceive? No, unfortunately, nothing that has been really proven, evidence-based proven. There are some studies that have been looking at the use of vitamin D and some of these natural vitamins and supplements in order to help medically manage uterine fibroids. But overall, the data is very mixed, and nothing really standard of care that we would suggest to go take and can help with reducing the inflammation or shrinking the size of these uterine fibroids, unfortunately. Are fibroids genetic? My mom has them, and so do I. Yes, they can be genetic related, related to genetic mutations, as well as hereditary and familial. Can you speak about pedunculated fibroids? So these are fibroids that usually have like a stalk, and they're kind of hanging off from the uterus, and typically there are outside of the cavity of the uterus. These fibroids, typically we're not too concerned about these fibroids when it comes to fertility and trying to conceive, because again, most of these fibroids are completely outside of the uterus, outside of the cavity, so we're not concerned about these fibroids unless they're big and they become symptomatic and cause symptoms. I have an intramural submucosal fibroid that is measuring 30 by 25 millimeters, so about 3 by 2.5 centimeters. Would you suggest to remove it before transferring the embryo? So if it's a submucosal, the submucosal component of it, yes, it needs to be addressed, because that's the part that is going to negatively impact, as we talked about, the environment of the uterine cavity, and can negatively impact implantation of an embryo. So you may want to proceed with a hysteroscopy, if possible, to have it removed hysteroscopically, since the whole fibroid, including the intramural portion of it, it doesn't seem to be that big in size, so about 3 by 2.5, and it seems like you only have one, so you should hopefully be able to have it removed hysteroscopically, just a minimal procedure, but the submucosal part of it needs to be removed prior to having the embryo transfer, in order to minimize, in order to help optimize implantation and to minimize the risk for having an early loss or miscarriage. If my fibroid isn't surgical, how long should I try to get pregnant before seeing you? So I'm not quite sure. I guess you mean that if you don't have the indications for surgery for uterine fibroids. So typical recommendations are to try to conceive for 12 months, at least 12 months, when you are younger than 35 years of age before you see a fertility specialist. For individuals who are 35 and above and older, if after 6 months of trying you have not been able to conceive, then we highly recommend that you see a fertility specialist. Typically in patients with uterine fibroids with an underlying risk factor, because we know that having fibroids is an underlying risk factor, I would recommend seeing a fertility specialist sooner than later, even if that means just getting some testing done, ultrasound and imaging evaluation of the uterus, just to make sure that the fibroid is not causing a problem or any impacts on the ability to conceive. So sooner than later because of this risk factor. So another great question, not sure if you went over this already. How would we know if the fibroids are causing infertility? All labs and tests came back okay. So a lot of this again depends on the location, the type of the fibroid, as well as the imaging study. So ultrasound, again, assessing the size, location of the fibroids, as well as further diagnostic imaging studies, including a hydrosonogram, 3D ultrasound, really evaluating the impacts of the fibroid on the cavity of the uterus would be helpful. Then there's another question about a left subserosal posterior fundal fibroid measuring about 2 centimeters. Is this the one that should be removed or of concern? So really, if it's a subserosal fibroid, again, likely this is a fibroid that is under the skin layer of the uterus, so really outside of the muscle, outside of the cavity of the uterus. Typically, these fibroids are not concerning. This one sounds like it's a very small one, only 2 centimeters, so likely you wouldn't have to worry about it, but obviously discuss this with your physician. All right, I think, great. I think this is great. I was able to answer all of those questions. So do we have any more questions? Emily, any other questions that I can answer? Oh, I just got another one. So thank you so much for doing this. You're very welcome. I have had two previous myomectomies. The last surgery was in 2019, where they removed 20 fibroids. A few fibroids have returned again in my journey to conception. Could the scarring from the surgeries impact implantation? I can't talk tonight, sorry. Theoretically speaking, it can, scar tissue can sometimes impact the ability to get pregnant after an embryo transfer, but it's one of those things, you know, it is what it is. What can you do about it? Yes, you have had two previous myomectomies with removal of so many fibroids, so I'm not surprised if you have already developed some scarring. So as long as, so the cavity, inside of the cavity of the uterus needs to be investigated, and that can be done by having an in-office hysteroscopy done, or by having a hydrosonogram study performed. And if any evidence of scarring, hopefully this is something that can be taken care of by having a hysteroscopy done. So if there's scarring inside of the cavity of the uterus, yes, that can certainly impact implantation and can and hopefully should be addressed for you. But there could also be scarring outside of the cavity of the uterus, and for that, there's nothing much that can be done. There could be some negative impacts of that scar tissue, but there's really nothing that we can do about it, and we don't want to put you through another major surgery because there's always a risk for scar tissue reformation. Listened with a cocktail while making dinner. This was so nice and calming and helpful. I am so glad to hear about that, and thank you so much for joining me. This is great. Sounds great. Having a cocktail while making dinner. Thank you so much for joining tonight. So I'll give it a few more minutes before we end to see if there are any other questions that... Okay, there's another question. Does hysteroscopy surgery decrease the ovarian reserve and AMH? No, short answer is no. So again, hysteroscopy is just a very minor procedure, and this is not something that is going to harm the ovaries. So anytime major surgeries or procedures that are going to be done that can potentially harm the ovaries, so any type of ovarian surgery, when we're trying to remove cysts, endometriosis from the ovaries, there's a potential for causing harm to your ovarian reserve. But hysteroscopy, again, very minor procedure, done vaginally, just taking a look inside of the cavity of the uterus is not going to impact your ovarian reserve or your egg quality. I think this is great. I was able to, I think, answer pretty much all of these questions. So thank you so much for joining me tonight. Again, please reach out with any additional questions, and our team of fertility experts here at Boston IVF are here to help you throughout your fertility journey. So please do not hesitate to reach out. Best of luck to you all who are trying to conceive and undergoing any fertility treatments. This can be a tough time, overwhelming, and fertility can be lonely and isolating. Hang in there, and please know that you're not alone. Oh, I got one last question. One question, maybe the last one. Are fibroids related to endo? Not necessarily. So endometriosis is presence of normal uterine tissue, endometrial tissue outside of the uterus that can be found on the ovaries, on the fallopian tubes, outside of the uterus, anywhere inside of the pelvic or abdominal cavity. They're typically not related. People with endometriosis may also have fibroids or vice versa, but they're not necessarily related to, say, people with fibroids are necessarily at increased risk for having endometriosis. They're two different conditions. And what causes fibroids to come back? Anything to avoid? That's a great question. Unfortunately, the fibroids do tend to come back and recur, can come back and can recur. And sometimes this has to do with the size or the number. So even after a surgical myomectomy, sometimes we're not able to remove all of the fibroids. Sometimes, depending on the location, access to fibroids may be difficult. Sometimes, depending on the size of the fibroids, not all of these fibroids can be removed. And even with complete removal of all of these uterine fibroids, because of all those unknown causes and genetic related factors, there's a likelihood that the fibroids may come back and may recur. And unfortunately, there's not much that we can do about it, or you can do about it. No medications really to take to prophylactically to minimize the risk for recurrence. And typically it can take time. Sometimes this takes many years, and they may come back or they may not. So it can be totally random. All right, we are going to end tonight's session. Thank you so much for joining me, everyone, and hope you have a great night. Thank you.